All right, good evening. My name is Paul Roettges. I am a fellowship trained orthopedic surgeon specializing in hip and knee replacements, as well as hip and knee arthritis and revision surgery and fracture care. And tonight I'll be giving a talk on hip and knee osteoarthritis. So thank you for coming, and feel free to ask any questions. We'll try to get to them all at the end and answer anything you might wonder about. All right, so what is osteoarthritis? Osteoarthritis is really a wear and tear of the protective cartilage cap on the ends of the bone. And over time, as the cartilage thins and wears, the underlying bone begins to have discomfort. And with that, people will grow bone spurs and have associated labrum and meniscus tears. And with that, the body will experience pain and often swelling. And over time, if this worsens, can get deformity and associated stiffness. So that picture, all encapsulated together, is what we commonly call osteoarthritis. Here are some examples of x-rays of a knee. So on the top left, you can see the x-ray there shows pretty good joint space between the bones. So the upper part is the femur bone, the lower part is the tibia. And between the two bones, you can see that space. And the space is there not because there's really a space, but that's where the cartilage is. And the cartilage isn't dense like the bone, so you don't see it on the x-ray. So you can see the top left still has a good cartilage space. Now, when we look at the middle images, you can say between the two knees there on the inside, the cartilage space is getting significantly thin. And with this, I'd kind of classify this as moderate to severe arthritis, mainly on the inside of the knee. And then on the bottom right image, you can see at this point, there's no joint space left on the inside of the knee there. You're getting some flattening of the joint surface and associated bone spurs there on the edges. These next are some examples with hips. So the left image, you can see the thigh bones have nice round balls on the femur, and the socket is nice and smooth. And between the ball and socket, there is a good cartilage space, indicative of relatively healthy appearing hips. And then on the right image, you can see the patient's left hip really has no joint space left and is becoming worn and flattened. And there is some cystic change within the ball and surrounding osteophytes. And we would classify this as severe hip arthritis. So what are symptoms that you would experience with arthritis? So for a knee, typically they have pain most frequently at the area of lost cartilage. So for most folks, that is more in the inside of the knee. However, it can be under the kneecap as well as on the outer portion of the knee, particularly if you have more of a knock knee type of alignment to your leg. Patients will often have significant flares of arthritis. They'll wax and wane. They'll have good days and bad days, good weeks and bad weeks. However, over time, this will typically just slowly worsen with time, as this is a wear and tear phenomenon. Patients often express a lot of nighttime discomfort, wakes them up from sleep. The first two steps when they get up are often stiff and with pain. And then they'll typically get into a little bit of a groove, feel better with some initial activity. And then after a long day's work or walking, they'll have increased pain once more. This can be associated with swelling. Often patients will describe pain in the back of their knee. This is frequently thought to be because the arthritis tends to wear out most commonly in the back of the knee, and that's also where you tend to get meniscus tears most frequently. And then over time, the knee will typically stiffen, and people will describe crepitus, which is kind of grinding, popping, catching of the knee. And often patients, although their ligaments are actually stable, they'll have a feeling of instability, like the knee wants to give out. For hips, classically, hip arthritis is really a groin pain. The pain is typically deep within the groin. Sometimes it can be deep within the buttock area. Patients will often make like a C with their hand and say, deep inside the hip, they feel pain. They'll get some radiation down into the thigh, and often patients can actually have some perceived knee pain with hip arthritis. Patients will also get associated stiffness. They'll have difficulty putting on their socks and shoes, difficulty lifting the legs. Sometimes they'll find themselves using their hands to help swing the leg up into positions. When evaluating for hip and knee arthritis, you often have to look for other potential sources of pain. Around the hip, that's often hip bursitis. That would be more commonly a laterally based pain. Patients will have discomfort when sleeping on that side. It'll be point tender. That often will respond to non-operative treatments and injections. Also, people can have some overlap of back problems, and that can lead to low back pain or kind of buttock area pain. Can also get some pinched nerves that can give numbness or tingling down the leg. And the lower leg and knee, sometimes swelling from medications or poor vascular will lead to swelling that can be perceived as knee pain. And if you have really minimal pain, but a lot of mechanical symptoms with locking or catching, this may be indicative of an isolated meniscus tear without that much significant underlying arthritis. So what do we need to evaluate a patient for arthritis? And really the take home on this is you mainly just need an x-ray. It's pretty simple. X-rays really tell you most all you need to know. As I showed earlier, you can really see the joint space, and as it narrows and becomes more of a bone-on-bone picture, that's really typically all you need to make the appropriate decision-making of what to do for it. Occasionally, if the x-rays don't show much loss of the cartilage space, but everything else is adding up to arthritis, we do get MRIs to look for the degree of cartilage loss. Also, MRIs can help if you have an isolated meniscus tear. And it's pretty rare to need CT scans or any sort of laboratory data. For patients that have rheumatoid arthritis or autoimmune conditions, sometimes we'll get some labs to see if that may be playing a role. Intermittently, we'll have to get a few additional x-rays than typical, than your normal primary care doctor may get. Typically, we like to get weight-bearing x-rays. That helps really delineate the loss of cartilage space. So what can we do now that we've identified that you may have hip or knee arthritis? So there's a wide array of treatments. As hip and knee arthritis is one of the most common conditions in the world, we've really tried nearly everything to try to alleviate pain. Then there are large guidelines that have looked at all the data and really try to break down what has been shown to actually benefit the patient. And one of the most commonly cited and appropriate treatment strategies is anti-inflammatories. And that's typically simply over-the-counter Aleve or ibuprofen. This is a class of medication called an NSAID. And these are non-steroidal anti-inflammatory drugs. There are also prescription versions of this, such as meloxicam, which is a once-a-day version. There is one called Celebrex, which is typically designed specific for patients with sensitive stomach and unable to tolerate traditional NSAIDs. And this has been shown in multiple studies to provide good relief, improvements in pain, improvements in swelling, and allow patients to continue with a very active lifestyle without any further intervention. This can be augmented with Tylenol, typically a very safe drug. Patients that have blood thinners or other cardiac concerns often use this as first-line treatment. And you can take both of these together, NSAIDs and Tylenol, very safe. One is broken down through the liver, one through the kidney. That's often concerns patient has, is that could it be taking too much of the same kind of thing? But they actually act in different mechanisms. Other things that we can provide that has good data behind it is tramadol. This is a low-level pain medication. I do avoid any sort of narcotic pain medication. That's not in the patient's best interest. And nowadays, a lot of people are looking for alternative oral medications. Most commonly, people will take turmeric, which is an all-natural anti-inflammatory supplement. And over the last few years, I'm seeing more CBD type products that maybe alleviate some pain. One of the classic original ones was glucosamine chondroitin. However, most studies really show that doesn't have much benefit. Lifestyle modifications is also one of the big treatment strategies. And this is pretty straightforward and simple. Really, if it hurts, don't do it. Most patients here, when they're experiencing arthritic pains, I tell them it's a no pain, no gain, or this is not a no pain, no gain type of situation. If you find yourself always aggravating your hip or knee with one particular activity, it's best to try to avoid that activity. We do sometimes send patients for physical therapy. However, this really shouldn't focus so much just on their hip and knee, as that'll probably flare up your symptoms, and really should focus more on your total body, aerobic exercise, heart and lung, aqua aerobics, swimming, elliptical, biking. All these things are low impact and tend to strengthen the muscles and the core without significantly aggravating the knee or hip. Also, weight loss is a big one. We know that every pound counts. They say something like 4 to 6 times your weight is put the force through the joint. So if you lose simply a pound, this is 4 or 6 pounds of force that you're eliminating through the joint itself. Also, weight loss is important when considering actual surgical intervention. We know that patients decrease their risks, such as wound healing problems or infection, if they're able to decrease their weight. And nowadays, with most surgeons really trying to limit all potential complications and have the best outcomes for the patient, there's pretty standardized national norms for weight around the time of surgery. One of them is called a body mass index. And it's been shown that if your body mass index is above 40, which is a simple calculation looking at your height and weight, that this does significantly increase your risk of wound problems and infection and other complications with surgery. And so, unfortunately, nowadays, most surgeons will just simply not operate on any patients that are above this cutoff to help prevent potential poor outcomes and complications for the patient. Physical therapy, we hit on this briefly, but really it's a wear and tear disease. You have to remember that. Certainly there are plenty of studies that show the importance of physical therapy in maintaining strong muscles and core. However, I try to avoid just isolating the hip or knee itself and doing aggressive therapy, as I have found that this often will provide more pain and then alleviation of symptoms. And so I really focus on a total body approach, more low impact exercises. Very rarely there is a indication for what we would consider be prehab, which is physical therapy prior to surgery. This is typically reserved for patients that are already heavily reliant on walkers or wheelchairs. With this, I think they can benefit from strengthening their overall core and working on strengthening their walking ability. Because after any sort of surgical intervention, it does typically take a step back. And so it's nice to have some existing strength prior to considering surgery. Ambulatory aids are always important. For a cane, people will typically use this in the opposite hand. So if you have right knee arthritis, you will use your cane in your left hand. Walkers also frequently used to help prevent falls. Really, the number one thing here is limiting falls. Last thing you need when you have an arthritic knee is to fall and break your hip or have another injury like a wrist injury or a back injury. Those would be the most three common. With osteoporosis, as patients age, they can get fragility fractures with simple falls. So important to try to strengthen your core, work on your balance, and use any sort of ambulatory aids as needed. With this, as we're talking briefly about fragility fractures, just an important time to give a brief plug on osteoporosis treatment. Although osteoporosis and osteoarthritis are completely independent and separate entities, osteoporosis is important to always be following up on. They recommend that postmenopausal women after the age of 50 are worked up for osteoporosis every few years with a bone scan. And if found to have any osteopenia or early signs of osteoporosis, typically they would start with vitamin D and calcium supplementation, and may also recommend medications to help limit further bone loss. Braces. This is a very commonly used thing, however, not very data supported. Unfortunately, some of the braces that actually will provide some stability and support to the knee, like that unloading brace seen in that picture, are often very big and bulky. And I have found that patients don't tend to tolerate these very well. Of course, some patients can, but a lot of patients find these to be uncomfortable and to slide down the leg and end up sitting in the closet. But that brace is designed to try to eliminate the force going through the bad area of cartilage. So if you have more cartilage loss on the inside of the knee, it aligns the knee so you put more weight through the outside of the knee, and vice versa in the other scenarios. Braces that are more commonly used are things like knee sleeves or neoprene braces with small side supports. And these are much more well tolerated and comfortable. However, really are not providing much structural support to the knee. They certainly can help a little bit with swelling and provide some warmth to the knee. And with that, patients do have some improvement. Typically with braces, I always tell patients that go ahead and try them if you like. I wouldn't spend a lot of money on them, but it's kind of trial and error. And if you find one that tends to work for you, then go ahead and stick with it. It certainly isn't doing any harm. Injections. So injections are one of the most commonly used treatments for hip and knee arthritis, particularly the knee. Most commonly used injection would be a corticosteroid injection. This is very cheap and covered by insurance and easily given in the office. Typically doesn't even require any sort of ultrasound or any advanced imaging. And I've found that this is typically very successful for pain relief, particularly in patients with mild arthritis. The more mild your arthritis is and the more acutely inflamed your knee is with swelling, the steroid tends to really calm down the inflammation. Now, it's important to understand that the steroid itself is not helping the arthritis. It's not putting the cartilage back on the bone. All it is doing is simply calming down inflammation in the knee. And with this, patients typically have an improvement in their symptoms. The real question is for how long. I've found that the more mild the arthritis, the more acutely inflamed, the more likely it is to help and to last for a long period of time. The more you have chronic bone-on-bone arthritis going on for many years, it is less likely to give you relief more than just a few days or weeks. But that is typically a good first-line treatment. It tends to be very safe and well tolerated. Patients tend to ask how much it's going to hurt. And in general, I tell them it tends to be very well tolerated. It's done very frequently each day and takes only a few seconds. And it's nothing more than just a simple stick of a needle. And most people actually get relief, particularly with knees, right away. They even feel later that day their knee feels better. There are a wide array of other type of injections. The second most commonly used would be what's considered viscosupplementation. That is a hyaluronic acid product. There are a whole array of them by different companies with names such as Synvisc or Monovisc, or there's Gelson, Homovisc. There's a lot of different options. They're all relatively the same product. There are hyaluronic acid and just created by different companies. Initially, there was some thought that this could really help lubricate the cartilage and give patients good relief. However, most of the more modern studies comparing it to blinded, randomized controlled studies have shown that it's not that much better than placebo. And with that, due to the cost of the injections, the current recommendation by the American Association of Orthopedic Surgeons is against its use. However, that being said, I still will use it intermittently on patients. There are certainly patients that swear by it and say that it really has helped for them. Again, I think the more mild your arthritis and sometimes more arthritis under the kneecap seems to respond better to this. It is very safe and is not going to cause any problem. It's really extremely rare to have an adverse reaction to it. But again, it is pretty expensive. And with some of the more modern data, a lot of the private insurance companies are beginning to deny its use. And so it is most frequently used now in a Medicare patient. Other type of injections that you may see out there are platelet-rich plasma or stem cell type of injections. For treatment of arthritis, there is really no data to this point that supports their use. They have not been shown to put cartilage back on the bone. Patients often will wonder if they can just hold off on getting that hip and knee replacement, and maybe in time they'll be able to get stem cells or other type of regenerative medicine to the knee. However, frankly, I think that is very far off. We are just learning how to turn a stem cell into a cartilage cell in a petri dish, and that's very different than trying to get that cell in your knee to turn into a cartilage cell and find the area of missing cartilage and bond there and really try to replenish your cartilage. So most of these things are cash pay, very expensive, and really, again, don't have data to support their use. So arthroscopic surgery. I'm sure everyone out there has had some friend that's had their knee, quote unquote, cleaned up or had some sort of arthroscopic surgery. Maybe they were told they were removing bone spurs or other aspects within the knee. Really, this has been done less and less these days. Most of all the studies show that arthroscopic surgery for hip and knee arthritis is not beneficial. And it makes sense. You know, this is a loss of the cartilage. By going in there and smoothing out a little frayed or torn edges, you're not putting the cartilage back on the bone. So it's unlikely that this is really going to give you a long-standing relief to your joint pain. It's certainly an enticing option. It's quicker surgery, easier recovery, but again, it just has a limited likelihood that this is going to give you long-term relief. There are some roles for arthroscopic surgery particularly in patients that have really a minimal underlying cartilage loss and more of isolated meniscus tears or labral tears in the hip. And that can eliminate some of the mechanical symptoms, the catching and locking that you may be experiencing, but typically not going to limit generalized pain. And for the hip, particularly in younger patients, if you're having some impingement type pain, where you're getting some abutment of the bone against the socket and tearing of the labrum, you may be able to help improve this with arthroscopic intervention. But by and large, for the large portion of patients experiencing symptoms associated with their arthritis, really arthroscopic surgery is of limited benefit. Joint replacement. So joint replacement really is the main surgical treatment strategy for hip and knee arthritis. And it really is when you've exhausted your non-operative treatment. So when you've tried your anti-inflammatories, you've modified your activities, you've attempted some low impact exercises, you've maybe tried an injection or two, and it's gotten to the point where you say, look, I just am not getting relief from this, and this is now affecting my quality of life and the activities I do on a day-to-day basis. And when you get to that point, the decision really is to proceed with joint replacement. It really comes down to a quality of life decision. It's for the patient to decide, not the doctor. I always tell patients, I'll simply tell them if I think their arthritis warrants joint replacement. However, it's really up to them to decide when and if they were to ever proceed with this. There really is no downside to waiting and trying to put off surgery if you are able to successfully treat this with non-operative treatments and injections. However, jokingly, if patients come back in, 3 or 4 years later and they're out of shape and depressed and they've had 3 or 4 additional years of hip and knee pain, just trying to put off surgery, that certainly is not in their benefit either. So I think there's a happy medium between not rushing into it, but also not waiting too long. So what is a joint replacement and what do we actually do? So I'll start with the knee here. A knee replacement is a midline incision right down the front of the knee. Typically takes about an hour-long procedure. And what it really is a resurfacing of the knee. So if you look at the x-rays there, the image on the right of the screen is a side view of the knee. And the side view is really what tells the story. And you can see it's not that we go in and really take out the whole knee. You simply just shave off the bad bit of cartilage and bone on the ends and apply a metal cap to each end. And that is typically held to the bone with the bone cement. As you can see, a little bit of the hazy white around the implant there. And between the two metals, you get a medical grade plastic under between the two metals, and you also get a medical grade plastic under the knee cap. And that's what we'd commonly consider a total knee replacement. You can see that with this, we would typically straighten and realign the limbs. So on the front view, you can see that right knee had a knock knee type position, and now after surgery has been straightened. It's important to know that we keep your medial and lateral ligaments, we keep all your muscles, there's no muscles removed or cut, and really it's just a resurfacing of the bones and removal of the bad missing cartilage and bone spurs. Like I mentioned before, most commonly this is done with cement to secure this to the bone. However, sometimes for younger patients, you can do this without cement and allow for the bone to actually grow onto the implants, as is more commonly done in hip replacement. One of the common things everyone will see nowadays is doing this with robotics or computer assistance or custom blocks. And the take home for this really is to know that none of this has ever been shown to make any difference in outcomes. So whether you do this with traditional measurements or traditional methods using measurements of the bone during surgery and to align and provide the appropriate knee replacement versus attempt to do this with robotics or other navigation, they've all been shown to have the same outcome. And one of the common misconceptions is that some of these in robotics or computer navigations may lead to a quicker recovery or smaller incisions. And really that's not true whatsoever. Unfortunately, this isn't like a robotic hysterectomy where now you can do this through a smaller incision with robotics. Really, the robotics still has the exact same exposure, same incision. Actually, typically we'll have additional incisions for the robotic instrumentations. So some addition for at least in my hands, typically is some additional time spent and additional incisions as compared to a traditional knee replacement. And again, it's the same knee replacement whether you get it done with or without robotics, and hasn't been shown to have any improved outcomes. So I use it selectively. Certainly, there are some folks that will benefit from robotics if they've had complex deformities or prior rods or other type of surgeries with their limbs that can get in the way of the traditional methods. But in general, a traditional knee replacement does extremely well and is very efficient. Also, robotics is pretty widely used in partial knee replacements, and I do think has some benefits in partial knee replacements, so that I do typically use robotics for all my partial knee replacements. So for hip replacements, what do we do with hip replacements? So I've done hip replacements from the front, the side, the back, every which way. I have really found that the direct anterior approach to the hip is beneficial to the patient. Any patient I've ever known that's had one from the front or one from the side or more traditional way in the back, they will say that the anterior approach is a quicker recovery. And I agree with that sentiment. The anterior approach is a 10-centimeter incision right in the front of the hip. The benefits of this is it goes between muscles instead of splitting any muscles or taking any tendons off the bone. And with this, that tends to make for a faster recovery and certainly makes for a much lower risk of dislocation. And because of that, I don't give patients any restrictions afterwards. And so after hip replacement, I expect you to be up and walking the same day. You can bend it, twist it, move it any which way you like. There's none of the old restrictions like not being able to sit in a low position or cross your legs or any of those things. As you can see on the image here, what a hip replacement entails is removal of the ball and socket and replacement with a titanium metal. Between the two metals is a ceramic head and a plastic liner. This is the most commonly used configuration of materials nowadays. It avoids any sort of metal on metal articulation and really has been shown to last 20, 30 years and beyond. And with with hip replacements these days, we don't typically use the cement or glue as we do in knee replacements. The wedge fit into the bone allows for the initial stability, and then your bone is actually able to grow into the implant to provide long-lasting adherence. What to expect around the time of a hip or knee replacement. So when you make a decision to proceed with a joint replacement, and typically you'll be sent for preoperative clearance. That'll be coordinated at our office, and we will send over a letter of different things like an EKG, chest x-ray, basic blood work that the hospital would like prior to a joint replacement. This would be sent to your primary care physician, and they would attempt to gather this information as well as a letter stating that you're safe for surgery. For patients that see a cardiologist or a pulmonologist or other type of specialist, sometimes you may have to see that physician as well to say that you're safe to proceed with surgery. Day of surgery, typically arrive around 2 hours before surgery. At that point, they'll get you checked in and get your IB. For knee replacements, we typically will have a nerve block performed by the anesthesia staff to help limit postoperative pain. The surgery itself takes about an hour, and then there's about an hour in recovery. And after that, we typically will shoot for trying to get most of our patients home if possible. And with that, we make sure that they're walking well up and down the hallways, up and down steps, everything they need to do by the therapist so that they are safe to go home. If they're deemed safe to go home by the patient themselves and all parties involved, and majority of my patients will go home typically the same day of surgery. Some patients that live alone or that may need some more care or longer recovery after surgery will stay overnight. And typically orthopedic patients get their own room and preferred rooms in the hospital. Again, there's no restrictions. I want you up and walking the same day, regardless of whether you stay in the hospital or go home the same day. Typically patients will use a walker at first and then subsequently wean from this to a cane and then to nothing. And for patients that may require a little extra assistance, we are able to arrange some home health physical therapy, or occasionally patients will go to a nursing facility or rehab facility if need be. So post-operatively, there really is no big bulky bandage or braces or drains or anything nowadays. So it's typically just a simple Band-Aid over the hip and knee. I will have patients keep this dry for the first few days, at which point they're able to remove this and take a regular shower. I do all my stitches underneath the skin with the glue over the top, so there's no staples or stitches that need to be removed. Typically makes for a nice sealed closure and a nice appearance in the long run. So in general, again, pretty simple with that. Rehabilitation afterwards certainly is very important for knees. Knees can get stiff after surgery if not appropriately rehabbed. It's very basic. It's simply just bending and straightening the knee and doing some walking. We will typically help coordinate this with an outpatient physical therapist. If patients are unable to get rides to therapy, we will arrange some home therapy. It's far less important with hip replacements. And most of my modern hip replacements these days, I don't even get formal physical therapy unless requested. It's never been shown to make a difference in the outcome. And typically, really, all hip replacement needs is to get up and get moving and just do some basic walking. And the most important thing with physical therapy is range of motion for your knee and weaning you off your walker and getting you up and back to your regular activities. So what are the outcomes? I think hip replacement nowadays is really considered one of the top 2 or 3 surgeries in the last 100 years. It's really our gold standard. It has extremely good outcomes. The typical patient will report that they are surprised how quickly they bounce back from surgery, and they wish they didn't wait as long, and they, by and large, have an extremely successful result. It tends to have a very natural feel. A lot of patients feel like they never had surgery even to begin with. And if need be on the other side, most patients don't nearly wait as long to get their other hip done if they have arthritis on the other hip as well. I've had patients tell me they're even back golfing as quickly as 2 weeks later. I normally tell patients to expect about 6 weeks for a full recovery, but often patients recover much quicker than this. Modern hip replacements really last 20 and 30 years and beyond. It's about a 95% survivorship at 15 years. So this really should be a one and done surgery for patients. The scariest realistic complication is an infection. It's about 1 to 1.5% nationwide. I have a less than 1% infection risk. We do everything we can to avoid that, and we take it very seriously. But by and large, this is a very successful surgery. For knee replacements, I'd say this is a very close second. It is the most commonly done surgery by Medicare, I believe, in the United States alone, about 700,000 each year. There is a little bit longer recovery than a hip replacement. The first few weeks are always a little tough. I try not to sugarcoat it with the patients and provide realistic expectations. We do everything we can to make it very tolerable. We give patients pain medications, anti-inflammatories, nerve blocks by the anesthesiologist, as well as numbing medicine at the time of surgery. Typically, that helps with the first few days to allow patients to be up and ambulating right off the bat. By about a month, patients typically really turn the corner, start seeing the light at the end of the tunnel. I tell most patients to expect about a 2-month recovery for majority recovery. However, patients will continue to really show steady improvement for the whole first year. This typically will get patients back to doing all their active lifestyle things. They'll be able to get back playing golf and tennis and other fun activities. The outcomes for knee replacement are also extremely successful. Most studies will show a 95% good or excellent result. That does include a small portion of patients that will have some minor discomforts or complaints, such as some sensitivity with kneeling. But by and large, this is a very successful surgery that will improve your overall function and allow you to get back into living a pain-free lifestyle. Again, whether this is a cemented or non-cemented technique, they both have excellent outcomes with survivorships of 20, 30 years and beyond and minimal failures. Again, the scariest realistic complication is an infection. In my experience, the last 1,000 of these, I've had one knee that's been infected post-operatively. And so we, again, have very high success rates. So to wrap it up, choosing a surgeon for you. How do you choose the correct surgeon? If it was me, I would say the most important thing I would look for would be a fellowship trained surgeon. And that means the surgeon not only completed their orthopedic training, but they did additional training just specifically in hip and knee replacements. And when you talk to a doctor, understanding the volume of their surgery is important. It's clearly been shown that higher volume surgeons, as well as higher volume facilities, have lower risks. So if your doctor is only doing a few of these, I would say that'd probably be a higher risk for poor outcomes. Certainly, there is some sweet spot that obviously you can be doing too much of these at one day and starting to cut corners. But in general, a higher volume surgeon, it does have much better outcomes. Other things people can look into are things like academic centers. They have some of the bigger names, but you have to understand that you will often have residents and fellows and trainees that will be involved in your care, and each patient needs to take that into consideration. And ultimately, you have to understand that hip and knee replacement is really a lifetime partnership between the surgeon and the patient. And so I think finding a patient that really meshes well, finding a doctor that really meshes well with the patient, that you're able to have good conversations with, is the most important thing, and because this is your partner now going forth. So I thank you for your time, and I'm happy to take any questions you may have. Certainly, that's my goal. I have patients out there running the river run. I have patients that are surfing and biking and skiing and mountain climbing, and so I expect to get patients back to doing very rigorous activities and without limitations. Yeah, that's a good question. So in general, most people around the country will say about every 3 months you could get another steroid injection. There's not a lot of science to this. In general, it's very safe and not deleterious to the knee. If you were getting a steroid injection every week or so, that could cause some thinning of the bone and osteoporosis. But typically about 3 to 4 times a year, it's very safe and without concern. Also a very commonly asked question. So that's a little bit of a misunderstanding. So no, the answer is no. You won't have return of hip or knee arthritis because the arthritis is technically a loss of the cartilage. And so by doing a replacement, you are eliminating the poor cartilage and bone. And so you are not able to have arthritis return to the joint. The one caveat to that is a partial knee replacement. I didn't talk about that much today, but in some rare settings, you may be a candidate for a partial knee replacement for your knee. There are benefits and cons of that. One of the downsides to a partial knee replacement is if you only replace the part of the knee, say the medial aspect of the knee, then over time you may have progression of your arthritis in the remainder of the knee. So this is also a question commonly asked. I recommend not doing knees at the same time. There are good studies that show that even in the youngest, healthiest patients, that doing bilateral knee replacements have increased risks, particularly very scary risks such as heart attacks, strokes, dying on the operating table. My experience in training, as well as my mentor's experience, has shown some increased complications and risk factors. And so I recommend staggering this. Now, how far to stagger is really up to the patient. I typically recommend at least 6 weeks between the two to allow for inflammation to calm down and the body to recover from their initial surgery. And every patient's really a little bit different on this. Some patients want to just jump right back on the bandwagon and get it over with. Other patients will put it off more like 9 months or a year later. So it really is up to the patient to make the appropriate decision for them. So I typically recommend swimming. That's obviously one of the best, but can be somewhat seasonal. Biking is typically very good and low impact. Things like elliptical are also good. Really, I just avoid kind of jumping, jogging. We know jogging is good for your overall health, but certainly hard on your joints. And one of the big take homes is really finding the right thing for you. So everyone's a little different, but if you have an exercise that's always aggravating your knee or hip, that's certainly one I would avoid. But in general, it's those low impact ones we mentioned. So also something we run into relatively frequently. And I always typically tell patients, it's really not your age, it's your overall health. I've seen very unhealthy 59-year-olds that are very poor surgical candidates. And I've seen very healthy 89-year-olds that are still out there doing all their regular things themselves and are very active. And so I don't think there's necessarily an age limit. I've done these in 90-year-olds, but it comes down to your overall health. The one thing I do take into consideration in older patients is the quality of their skin. So particularly over the knee, if the skin is getting very thin, I do think that does add a little bit of increased risk of wound problems or wound breakdown. And it's simply just that it's hard to stitch closed very thin skin. But that's the main thing from a surgical standpoint. And then the other thing is just medical considerations for patients with more medical complicating factors. So again, my name is Paul Roettges. I am here with Southeast orthopedic specialist, specializing really in hip and knee replacements. That's pretty much all I do. I always jokingly say I'm a two-trick pony. I do many hundred of these, about 600 or 700 this year alone, hip and knee replacement surgeries. And as of right now, I'm mainly located in our St. Augustine region. I see patients in St. Augustine. I also see patients in our 210 clinic there in between St. Augustine and Jacksonville. I operate significantly out of Flagler Hospital, and I will also be operating out of the new St. Vincent's at 210 for patients that may find that more convenient for the Jacksonville region.